Hello, my name is Douglas Shook. I'm the Chief of Cardiac Anesthesia at Brigham Women's Hospital, and we're going to spend 30 minutes today talking about the role of sonography during cardiopulmonary resuscitation. And this actually ends up being a fairly complex talk and very, I think, interesting, especially with some of the information that's come out over the past couple of years. I have a couple disclosures. I do education and consultation work for Edwards Life Sciences and education work for Baylis. So, are there indications for perioperative non-cardiac transesophageal echo? And I know this isn't bedside, but it's important for the story. So actually for cardiopulmonary arrest, transesophageal echo is really helpful. This was a paper that came out of our institution in 2006. We looked at our database at that time for 22 patients that had cardiac arrest and a TE probe placed. And we found that transesophageal echo was really great at making a diagnosis of what was going on in the arrest and aided in treatment in 82% of the patients. And actually, about half of them led to a surgical intervention. And I'm going to stick to the ones that did well, but you can see here, and you'll see on the slides in the syllabus when you get it, you can go through each one of these yourself. But we have a patient with normal biventricular function who needed fluid resuscitation. That was one reason for the cardiac arrest. Patient with a pulmonary embolus. Patient with new regional wall motion abnormalities that led to a CABG. Another patient that had pericardial tamponade from RV rupture, which led to RV repair. Biventricular regional wall motion abnormalities, which led to intra-aortic balloon pump pacement in the patient. And another with LV regional wall motion abnormalities, which ended up being an acute myocardial infarction. All these patients did well and ended up surviving to hospital stay. But as you can see, some didn't do as well, and obviously some did not survive. Again, another paper that came out in 2005 that in 8 of 10 patients, a diagnosis could be made with regard to the reason for the cardiac arrest. And this is a paper from our institution, again, from 2015, which looked at 10 obstetric patients with severe hemodynamic instability. 6 proceeded to cardiac arrest, and TE determined the etiology of the arrest and guided resuscitation in all of those patients. So where does echocardiography and CPR, what are the benefits? And actually it can make some very good diagnoses that can lead us in a particular pathway. One of the things about cardiopulmonary resuscitation is obviously we want to keep blood circulating. We want to have oxygenation of the vital and circulation of the vital organs, but it's also helpful to come up with a diagnosis if there's one to be treated. And so the common diagnoses made from echocardiography include myocardial infarction, pulmonary embolism. You can see over here tamponade, hypovolemia, aortic dissection, aortic rupture, and of course you can diagnose asystole. And you see we have a number of articles from which I created these conclusions with. The other thing is sometimes if you don't make a diagnosis, the good thing also is you can exclude treatable problems, as I see here up in the right-hand corner. Or a lot of times, if you see a lot of spontaneous echo contrast, those patients tended to fail CPR. And one of the key things we noted way back then was that you can continue cardiopulmonary resuscitation while performing the TE exam, which ends up being an important caveat when we compare it to transthoracic. So if you look at our practice guidelines for perioperative TE, the one that has the highest importance in the non-cardiac patient is if equipment and expertise is available, TEE should be used when unexplained life-threatening circulatory instability persists despite corrective therapy, and I call this rescue TEE. The second bullet point describes TEE as an intraoperative monitor. So let's take a look at when TEE should be used, rescue TEE specifically. So this is a patient who's 50 years old, not a significant past medical or surgical history, who's having an orthopedic procedure, develops hypotension that becomes unresponsive to volume, and the blood pressure continues to drop. So a TE was ordered because the patient because CPR was initiated. So you can see here the hypotension, and this is a mid-esophageal 4-chamber view. The patient is here, and the larger image is the patient. The smaller image is a normal 4-chamber view, and you can see here the The ventricle isn't contracting as well, and the right ventricle, which is harder to see in this shot, is significantly hypokinetic. So as we continue, you can see here, right side is enlarged, dilated. You can see the right atrial septum's bulging to the left, saying that you've got high right atrial pressures, right ventricular pressures, right ventricle isn't contracting well. And then you can see here that obviously this patient is having a pulmonary embolism. And in fact, the embolism has, you can see up here in the upper and the left atrium here, that the patient must have a PFO, because you can see embolic material on both the left and the right side of the heart. So cardiac arrest subsequently ensues. And what you can see here again is when cardiac arrest ensues, with transesophageal echo, we can actually monitor how well we're doing chest compressions. Are the chambers compressing? Can you see blood flowing from the mitral valve into the left ventricle? And if we did a long axis view, you could see if blood was flowing out of the left ventricle into the aorta. This is especially helpful if you don't have an arterial line, to help us determine how successful, how well are we doing our chest compressions to promote circulation within the patient. The patient ended up going on cardiopulmonary bypass for a pulmonary embolectomy, and you can see actually did quite well post. So this is another patient. This patient's having a laser lead extraction. And if you don't know about these are where you use a laser sheath to remove leads that are kind of chronically embedded in the right side of the heart. And you can see leads over time not only get embedded into the right ventricle, but get embedded into the tricuspid valve. So for most of these patients, this is a case where you prepare for blood loss just in case something untoward happens. And in this patient, you can see here, this is, if you haven't seen one of these, this is the interventionalist pushing this lasing catheter over the lead. And this patient had an ICD. And you can see that sometimes it goes easy, but also like here, right here at the IVC RA junction, it can be very difficult to get over that section, as you can see there. So the patient developed hypotension while this was occurring. And again, we're doing cardiopulmonary resuscitation, we're following ACLS, but the TE probe is placed while ACLS is commencing without stopping ACLS. And you can see here that there is a pericardial effusion. And it's quite significant. This is a transgastric short axis view. And the effusion is significant enough that we are quite hypotensive, and we end up doing a sternotomy. Here again, right ventricular failure. You actually can see blood starting to coagulate, and this is the descending thoracic aorta. And you can actually see thrombus at the apex of the left ventricle. Again, here you're witnessing cardiopulmonary resuscitation, chest compressions. Actually here, this actually may be compressions directly onto the heart. Again, you can see here, thrombus in the left ventricle. And I'll be quite honest with you, I was involved in this case. I didn't expect us to have a good outcome. Here we are post-bypass. The heart's actually functioning quite well. We repaired the rip that occurred at the IVC RA junction, or SVC RA junction. And we have here no blood or thrombus anywhere in the heart. And you can see good function. And actually, we wrote this up. This patient the next day was walking around the floors. Unbelievable. So again, a really great image or way, a really great, wonderful opportunity how echocardiography not only helps guide the resuscitation, but can make the diagnosis. So what about transthoracic echo? What about doing things at the bedside? What about transthoracic echo in the operating room? So let's take a look at this. So why is transthoracic or a focused exam using transthoracic echo of the heart relevant? Well, actually, I view it as an emergent or even disruptive imaging modality to help guide patient care. It's putting ultrasound in the hands of a larger group of people. And you don't necessarily have to be as expert as, say, a cardiac anesthesiologist or a cardiologist to have this become a relevant piece of making diagnoses in the patient. As I said, it brings improved care to the bedside. So so we can go to the patient, make diagnoses. Importantly, also, I think it keeps us as anesthesiologists on the cutting edge of educational initiatives for medical students, residents, fellows, and practicing physicians. And it's actually already in the ABA, right? Our residents who are taking OSCE exams already have to interpret echocardiograms, transthoracic and transesophageal, as part of their ABA examination process. And just as an example, all of us are, just because we all think, well, we have to be experts at ultrasound. But the reality is, I would say we're all very different in our ability to perform a physical examination and make diagnoses off of that physical examination. Some are going to be better than others. But if we incorporate ultrasound as part of that examination, say specifically for the heart, it makes all of us better on our accuracy of bedside diagnosis. So it's just another tool in our armamentarium to help us become better physicians. So what about transthoracic and CPR? Because I was talking about how wonderful it is for transesophageal. Does transthoracic have its role? So here's a case. Now this is an intraoperative case, but it's transthoracic for cardiac arrest. The patient was having a right IJ tunneled line for chemotherapy. Sedation for, the patient was having sedation for the anesthesia, but while the procedure was progressing, the patient developed hypotension, eventually tachycardia, and arrest. So while performing ACLS, a transthoracic, because it was under sedation, a transthoracic echo was immediately brought to the bedside, and a subcostal 4-chamber view, as you see here in this picture, was performed, which is one of the easier images to learn how to obtain. And you can see here, left atrium, left ventricle. Here's our right ventricle. You can see fluid above the right ventricle. There obviously there's a pericardial effusion and a perforation that occurred. So quick diagnosis made that during the placement of the catheter, the right side of the heart must have been perfed, and therefore an effusion occurred, which needs treatment. So that prompted an emergent pericardiocentesis. Fluid was drained with improved hemodynamics, and the patient did well. And a follow-up transthoracic showed a stable heart, well-functioning heart, and no effusion after the pigtail was placed. So we can see that use of, again, perioperative echocardiography is very important in our perioperative patient population. So this was a study by Sasha Shilcutt out of University of Nebraska, looked at 31 patients, and patients were echoed for perioperative hemodynamic instability. It could have been preoperative, intraoperative, or postoperative. It was a mix of transesophageal and transthoracic. All 31 patients recovered in her study, and 25 were discharged. Again, in her example, what were the common diagnoses? It's the same ones I mentioned to you when I looked at TE: hypovolemia, ventricular fail, myocardial infarction, pulmonary embolism, tamponade or pericardial effusion, and valve abnormalities. This one was in Resuscitation in 2015. This was very specific for transthoracic echo and CPR. It was a prospective cohort study, and they looked at 49 patients with asystole or PEA. So if they had shockable rhythms, of course you shock first. But if the patient doesn't have a shockable rhythm, and as we know, PEA, you're always looking at what's the diagnosis behind the PEA that you can treat to help alleviate the instability. So in this cohort of patients, image quality was adequate in all patients, and survival was best in patients with PEA. And you can imagine that's because there was probably something to treat that was diagnosable with transthoracic echo. So let's look at this patient. 80-year-old patient, long surgery with lots of blood loss. Was ready to transfer to the ICU, but then there was escalating vasopressor use, hypotension, and on the verge of cardiac arrest. So a transthoracic echo was performed in the operating room prior to transfer. Again, let's go back to that subcostal 4-chamber view. Right atrium, right ventricle, no effusion this time over here in the lower right corner, but you can see this left ventricle actually functioning quite well, but completely empty. And if we do a parasternal short axis, right here, you can see here, ventricle in diastole is when the heart's open, as broad as it is in diastole, that's when you measure your preload, but very small left ventricle. This patient needed volume. So hypovolemia was noted on the exam. Patient was given volume, pressors weaned off, and transferred to the ICU. So although the anesthesia team felt they had adequately resuscitated the patient, Again, the transthoracic echo showed us something different. Last case is a patient had a carotid endarterectomy, developed hypotension in the PACU, received fluid and phenylephrine, but was starting to get more and more short of breath as if they were, like a cardiogenic heart failure. Transthoracic echo was performed. Here's our initial image and our subsequent image. And you can see here, right side of the heart looks pretty good, but left side, actually you can see this mid to apical hypo to akinesis. Interesting. This is that kind of that stress heart, Takotsubo's. So in this case, it wasn't neo, it wasn't volume. Actually, this patient probably had volume overload, needed some support with epinephrine. And just to make sure that there wasn't underlying coronary disease, the patient went to the cath lab to find clean coronaries. So a very nice diagnosis just prior to before the patient became more acute and hemodynamically unstable. Transthoracic echo tells us what we need to do. There's a lot of algorithms for using transthoracic echocardiography and CPR. And if you look at these, and again, you'll have access to this offline. If you look at examples of these two algorithms, what you're going to see is incorporating the transthoracic echo during times where you're not doing chest compressions. Because obviously it's very difficult to do transthoracic echo during times of chest compression. And a lot of times what you'll see is the very first one you'll get in all these algorithms is that subcostal. So you'll be doing your chest compressions. When you do your pulse check, you need to run right in and get that subcostal view to see if there's anything that will help you in guiding your resuscitative effort. Now, again, this is, if you look here, ongoing CPR, non-shockable rhythm. Well, is transthoracic, what are the societies, or what are the statements when we reviewed use of transthoracic and CPR? And interestingly, you can see this came out in Circulation in 2020. In their treatment recommendation, when they looked at use of transthoracic and CPRs, we suggest against the use of point-of-care echocardiography for prognostication during CPR. Weak recommendation, very low certainty of evidence. And if you look at this update in cardiac arrest in emergency medicine clinics of North America, this is from 2020 also, it says if you go from highest priority to lowest priority of things you would do, what they have on their lowest priority is perform point-of-care echocardiography only if it does not delay other resuscitative efforts. So what's happening is when the studies that are out there, when they look at use of transthoracic during CPR, what they're finding is it delays going back to chest compressions. And as we know, effective chest compressions and circulation of blood during the resuscitative effort is one of the most important things we do. So if we're doing something that delays us doing that important piece of the resuscitative effort, then the question is, should we use it? And one of the issues is well, is this truly giving us information that is saving the patient's life? I would say in the end, I have to believe that in the right patient population, which I think we need to define further, transthoracic echocardiography is of benefit. And the other piece is we just have to become better at how to incorporate it into the CPR process. So interestingly, a number of articles, this one I just popped up was from 2020, focused transesophageal echocardiography during cardiac arrest and resuscitation. It was a JACC review topic of the week at that time. And what they see is, and this is their conclusions overall in picture format, is it enhances, you can monitor the quality of the CPR. You can it has a diagnostic role and procedural guidance. So say you diagnose and then guide the patient getting ECMO all in one. You don't have to do anything else. And a prognostic role. Are you at cardiac standstill? Is the heart at least beating a little bit versus organized or disorganized contractions? A number of things you can do to help guide you in your resuscitative efforts. And I showed a couple examples of this where up here in the upper right-hand corner, an example of is our chest compressions adequate? And another example of where we made a definitive diagnosis to guide us down the right path to guide our resuscitative efforts. So in summary, I think both modalities are really important. Transthoracic tends to be less invasive. You can do it in awake patients. You need access to the chest, where transesophageal is obviously more invasive. The patient typically needs to be sedated or intubated. Usually, typically not a problem in a patient who is an extremis. Are there contraindications? Does the patient have esophageal issues? The image orientation is opposite between the two, but things we've kind of highlighted. Transthoracic in the resuscitative effort is an intermittent monitor, where transesophageal has the ability to be a continuous monitor. Transthoracic interrupts CPR, or as I would like to say, you need to integrate it with CPR and do it effectively. That's one of the downsides of transthoracic that's being spoken about, where transesophageal echo is a continuous monitor of CPR. So both, I think, really good. I think as anesthesiologists, we need to understand the pluses and minuses of each and become skilled. My NPs both have perioperative applications for anesthesiologists. Both are good modalities. Both are things that we should become familiar with. Thank you very much.